All right, next we have Dr. Daniel Sokolowski. He is a clinical pharmacist here at UAB. He talks to every patient of ours who starts targeted therapy, and he checks in with them. He has a lot of wisdom over the years taking care of the patients with us and part of our program. So I'm very excited for him to talk about targeted therapy, the good, the bad, and the unaffordable. That's a catchy title.
Hey, so I'm the lymphoma and the histiocytosis pharmacist here, and since the doctor's already covered a lot of the physiology, I'm just going to skip over a few of my initial slides, but I do not have anything to disclose. As far as these targeted therapies go, our main goal is trying to improve quality of life, and so that's a big balancing act between the cost, the side effects, and then also whatever disease symptoms you're having and trying to get rid of those. Oh, sorry. Thank you. So I'm not going to go over all of this, but just wanted to point out that BRAF being the most common mutation, it is in that MAPK pathway, and we are going to use several targeted therapies that will go toward that, already discussed. And then MEK is at the end of the pathway. And so for any other mutations, or even if you don't have an identifiable mutation, the MEK inhibitors can be used. And in most cases, we're going to use the half dose or the middle dose for these drugs. So when I put up all the dosing possibilities, just know that we're usually starting off in the middle because histiocytosis is so responsive to many of these medications. So no point in using the highest dose and causing more side effects unless there are very specific situations such as CNS tumors that are not responsive to lower doses. We may need to increase to the highest possible dose to penetrate into the brain tissue and treat those diseases. You already saw this slide, but I did put a big red box around the most common drugs and the ones that I'm going to focus on today. So we have vemurafenib or Zelboraf, Cotellic or cobimetinib, and then trametinib and dabrafenib are our backups for those treatments. So what are these common medications? Well, looking at Cotellic or cobimetinib, it is a MEK inhibitor. We're going to treat the patients with 21 days of therapy, and then you'll have 7 days off. We can modify that extensively depending on how you're responding, as well as what kind of side effects you're having. So we do a lot of different treatment regimens, 14 days on, 7 days off, 21 days on, 3 days off, doing all kinds of things to try to make it as effective but also as tolerable as possible for these patients. The biggest side effects that we're going to see that are troublesome are going to be the drops in blood counts, and that's going to happen with every one of our drugs. And so we'll talk a little bit more later about how we're going to monitor that and the different things that you can do at home if you start to notice any of these side effects. But that's probably the biggest thing. It's going to happen in every patient, so it's not a possibility. It's just how much is it going to happen and how much will that affect your day-to-day life, and we'll talk about that. The next thing that we are going to be watching for are the rare but serious side effects, things like cardiac symptoms that Dr. Linneman will talk about later, as well as changes in vision. Just to point out, any of these drugs that have changes in vision, they are not permanent. So if you have blurry vision, loss of night vision, anything like that, talk to your doctor right away so that there's no damage that occurs over time. We can stop the drug and the vision will return to its baseline level. So that's just one thing that you don't have to worry as much about as with some of our other chemotherapies. As far as other symptoms, the biggest things that we're looking at are the organs that grow and divide the most. So you're going to see a lot of dermatologic issues, so skin reactions. We're going to see a lot of GI upset with these drugs, and we're going to be trying to treat those, and the best way to do that is for you all to communicate with your pharmacist or with your physician's team just to figure out what over-the-counter products and what prescriptions are available. So our other MEK inhibitor that we're going to use is going to be Mekinist, And when we're looking at this drug, it's going to be continuous. So rather than doing the 21 days on, 7 days off, we're looking at daily treatment. Again, we usually use the middle dose for this drug. It does need to be refrigerated, so that's something to think about whenever you're getting a drug delivery, is making sure that you're going to be at home to put it in the fridge as soon as it comes out of the packaging. And then it has very similar side effects to the Cotelic. We have seen, though, when switching someone from Cotelic over to Mekinist, that it's going to be a different set of side effects for each patient because your body's going to respond to those drugs differently. So if you have some intolerable side effect from Cotelic, we can switch to Mekinist and see a decrease in the number of side effects or a change in the type of side effects that you may have. So our next thing is vemurafenib, or Zelboraf, as we were talking about earlier. With this medication, you do need to avoid grapefruit, so that's one of our considerations with a lot of these drugs, and it can be taken with or without food. Our biggest problem with this drug is usually the number of tablets that patients have to take. It's only available in a 240 milligram tablet, and it does have to be taken twice a day. So I know when you get up, especially into the 960 milligram dose, you're taking 8 tablets a day. That can be a little cumbersome for a lot of patients, and we do recommend just making sure you have some food on your stomach so that it doesn't cause any nausea, since it does have that GI upset as a factor. With the Zelboraf and the BRAF inhibitors, they do have a little bit of a different problem with the cardiac symptoms. So rather than checking echoes, which is what we do with most of these drugs, we're actually going to be checking EKGs because it interferes with the electrical activity of the heart rather than affecting the muscle tissue. So if you ever are put on a BRAF inhibitor, that's one of the things that we do want you to be aware of and follow up with your cardiologist about that. Still has the same problem with decreased blood counts. When you see QT prolongation up here, one thing I do want to point out is that is the electrical activity of the heart. So it's going to cause a change in the gap between your heartbeats, and your heart will try to compensate for that, which can cause arrhythmias. So if you ever have anything like chest pain, pain shooting down your arm or down your back, sudden shortness of breath for no reason, we want you to get to the hospital, tell them you're on this drug, whatever symptoms you're having, so we can get an EKG in the moment so that we can see what kind of arrhythmia is going on, and then we can get Dr. Linneman or the cardiology team involved so that they can tell us what to do about that. Let's see. So our other option here is Tafinlar or dabrafenib. Very similar to the other BRAF inhibitors as far as our side effects go. The difference with this one is that it does need to be taken on an empty stomach. So whenever you're planning your day, make sure to schedule your medication around your meals. And it is only taken once a day, so it is a little bit easier than the Zelboraf as far as planning that out and getting it around the meal. One weird thing with this drug is the G6PD deficiency. So if you happen to be one of the very rare patients who has that and you know that, we will not give this medication because it won't be broken down as easily by your body and excreted as patients who have a more functional G6PD, which is just an enzyme that helps to break down medications and get them excreted through the liver. So there's all these other medications I don't have time to go through today, which I'm sure everybody's happy that they're not going to listen to all of these. But I did just want to point out there are all the targeted options. So, you know, as Dr. Reynolds was pointing out earlier, it becomes quite complicated when you're looking at all of these mutations. But then for patients who we don't know their mutation status and they need treatment right away, or if there's nothing that's targetable or you weren't responding well to one of these targeted therapies, there are a couple of chemotherapies, so cladribine and methotrexate, as well as immunotherapies. So we've got the PEG interferon, sirolimus, and anakinra, which are all available for you to use. Then we also have other medications that I can't even get into the long list of different trials and different things that have been done with a ton of different groups of medications, but depending on your presentation, specific mutations, different things that we're looking at, there are other options out there. So as far as side effect management, the biggest thing we're going to be looking at is those decreased blood counts. And with decreased white cells, you are going to be at a higher risk of infection. So any patient who's at a higher risk of infection, the main thing that we're going to tell you is use good hand hygiene, make sure you are treating your food well so you're not like leaving anything sitting out on the counter and then going and eating it, and make sure that anytime that you're going to be in a crowd that you wear a mask just so that you prevent anyone that you don't know from coughing on you or coming in with a fever and causing infections. With low hemoglobin, the biggest side effect is going to be fatigue, which I've actually got later. And then with platelets, our biggest risk factor is going to be bleeding. So as those platelets drop, we don't expect you to have any kind of spontaneous bleeding with any of these targeted therapies. The platelets aren't going to drop low enough to cause nosebleeds, GI bleeds, anything like that. But what we do worry about is accidents. So if you were to be in a car wreck, if you're fall and hit your head, fall off a ladder, anything like that, we do want you to get checked out at the ER, even if you feel okay in the moment, just so that there's no internal bleeding that gets missed or there's no problems that occur from not being treated. The derm side effects get a little bit more complicated. And the main reason for that is that I can't identify rashes. I don't know if you've ever seen the dermatology textbooks, but there's hundreds of different pages about how to identify rashes, and I am not an expert in any way. So I can tell you a cream or an ointment, and it may not be the right one for that type of rash. So I wouldn't go to a pharmacist to ask about this. I actually tell all of my patients to take a picture of the rash and send it to the nursing team, and they'll show it to the correct nurse practitioner or physician that's available to say what kind of rash it is, and then I can come in and I can tell you, what the best ointment is going to be at that point. So I don't diagnose, but that's my recommendation. And after that, the other biggest complaint I get is dry skin when it comes to derm. With dry skin, using any kind of unscented cream after a shower is going to be the best way to soothe that skin, and then use it as needed throughout the day. So if you notice that your skin's getting dry or cracked, then that's going to be when you want to use those creams. And I do recommend a cream because it's going to add kind of a protective barrier. It's not going to absorb in the way that a lotion does. The other thing to think about with any of these drugs is that most of them do cause some sun sensitivity. So you've got to watch out for UV rays. In most cases, you're using some protective barrier. So I've got a lot of shirts that have UV protection on them. I do recommend those. And also adding the SPF 30 or better for any kind of sunscreen that you've got available. And that's going to give you the best protection from sunburns. I will say your sensitivity to sun is going to be different than the person next to you. So don't expect that you're going to react the same way. You've got some patients who I've seen that have gone to the beach and not had any problems, and I've got a patient who told me that she stopped to talk to a neighbor at the mailbox for 15 minutes, and she ended up with second-degree sunburn. So what you can handle may not be the same as everybody else, so just be aware of that. The next thing that we do see is acneiform rash. That's especially prominent with MEK inhibitors, so something like Cotellic. Usually just using over-the-counter acne creams is totally fine, and you're not going to have any other issues after that. We do have a few patients that continue to have pretty large acne outbreaks, and we can use oral antibiotics like doxycycline to help treat those. So always talk to your doctor if you're not able to get that acne cleared up with over-the-counter treatment. Check your skin regularly. I put down the ABCDEs of skin cancer here. So if you notice any changes, any new spots, anything that's changing color or shape, then that's something to get checked out by a dermatologist. If you don't have a dermatologist, definitely go to your oncologist so that they can get a biopsy done and see what kind of cells are growing in that area. Sometimes it's benign, but a lot of times we do see patients that have basal cell carcinomas or squamous cell carcinomas that do need to get removed before they penetrate deeper into the tissue. And then other than that, just follow up with dermatology, and if you ever have to miss an appointment, always try to reschedule right away because they're a pretty hard group to get in with. The next thing we see is GI issues. And with this, I usually tell patients, I can't tell you how you're going to react because I've had patients have diarrhea and another patient have constipation on the same drug. So why one person reacts one way and one person reacts another, we don't know. We're not smart enough to figure that out yet. If we do figure it out, we'll definitely tell you. And then we also have some nausea. And nausea should never become vomiting. So if you ever have nausea or feel like you can't tolerate food, we want to know about that right away so that we can get you on some medications to prevent that nausea. We also recommend taking most of these medications if they aren't required to be on an empty stomach. Have a little bit of food to help settle your stomach when you're taking the medication. Drink plenty of water and eat throughout the day. We don't want 3 large meals because that can cause more issues than if you eat 4 or 5 meals throughout the day. So next thing we see is joint and muscle pain. And I'll tell you, you can use hot packs or cold packs. Use hot packs if you have the muscle pain. That's going to help loosen up and stretch those muscles. If you have joint pain, we recommend cold packs because that's usually caused by inflammation in the joint, and the cold can help with that. Always try to stay as active as possible. You want to keep moving those joints and muscles so that they don't become tight and tense. And if you're not able to tolerate activity or if it's interfering with your daily life, we've got OTC product or over-the-counter products and then also prescription strength medications to help handle that. Final thing is going to be fatigue and organ function. So fatigue is the big one that I don't really have any great medications to help with. It's going to be lifestyle modifications. Try to exercise about 20 to 30 minutes every day. Do that as soon as you wake up in the morning, get your blood flowing, get yourself woken up, and then schedule in a time to take a break, stop, and rest. And then as far as liver function, this also goes with kidney function. If you see any changes in your urine, if you see any yellowing of your eyes or skin, we want to know about that right away so that we can monitor those organs. In most cases, it's not going to be that severe, but if you do notice any changes before we do on your labs, then we want to know about it. So other considerations, we already talked a little bit about grapefruit, but most of these medications get processed through your liver, and grapefruit does interfere with the breakdown of those medications in your liver. So just try to avoid grapefruit and grapefruit juice containing products. There's also sour oranges that are from Asia that have the same chemical in them that the grapefruit does. Mostly used in marmalade, so it's not a problem because there's so much sugar in that it's not going to affect you as much unless you're eating a half gallon of marmalade. And then we already talked about the nausea, just making sure to eat meals and snacks with that. Finally, we talk about the cost. So I fight with insurance companies every day. That's my job, not yours. So if you have a problem with your insurance company, call your pharmacist and we'll yell at them as much as we can. We get paid for it, you don't, so come to us. And there's a lot of different processes that go through this, so try to be a little bit patient with us. We do have, PAs, appeals, calls to the pharmacy, insurance, and peer-to-peer, where I actually lean on our physicians to help me yell at the insurance companies. So other than that, there are several different groups, including Blood Cancer United, who's here today, who can try to provide grants. We try to get copay cards for anybody who's commercially insured, and then patient assistance programs where the drug company will actually provide the drug to patients whose insurance is giving them trouble. So we do all of those things, work with our social work team and physicians to make sure all that paperwork's filled out. And if you have any questions, I know we're running a little late, so I'll be outside with everybody, and feel free to come up and ask anything you would like.